Good afternoon, everyone. Good day, whatever time it might be where you are. My name is Ramses Pegwankam. I am a fourth year medical student at the University of Cape Town and also the head of research at the UCT Surgical Society. I'm joined by
I'm Samia Borat, a third year medical student and the head of career development, part of the society as well.
And my name is Jordan Kato. I'm a second year medical student and I'm part of Samia's subcommittee.
Okay, so welcome to Surgical Soul, and this is a podcast where we'll chat everything medical and beyond. And for our very first guest, our inaugural guest to the podcast, we have the pleasure of having Professor Lydia Cairncross with us. So I'll just introduce her briefly. This introduction could not do justice to who she is, but nonetheless, she will give you an idea of who we're talking to. So Professor Lydia Cairncross is a specialist breast and endocrine surgeon, and she serves as head of the Department of Surgery at Groote Schuur Hospital in the University of Cape Town Academic Complex. Though she was born in South Africa, she grew up in Zimbabwe before returning to South Africa to complete her high school education. She attended medical school at the University of Cape Town, where she acquired her MBCHB with first-class honours. And she followed this up with an internship at George Regional Hospital and community service in the Eastern Cape at both Livingston Hospital and Mthatha Academic Hospital, which is now known as Nelson Mandela Academic Hospital. Professor Cairncross completed her surgical training at the University of Cape Town as well, whereupon she was awarded the Douglas Medal for being the top candidate in the country for her College of Surgeons Fellowship examinations. She went on to complete subspecialty training in endocrine and breast surgery, again at UCT. She was awarded a professorship at the University of Cape Town in 2023, where she gave a powerful inaugural lecture entitled From Endocrine Surgery to Access to Care, the Imperative for Health Equity Action in Academic Medicine. Professor Cairncross is a recognized national leader and published scholar in her subspecialist field of surgery. She has played a pivotal role in developing context-appropriate national policy guidelines for breast cancer and endocrine surgical conditions. Her innovative system-based research is instrumental in promoting earlier diagnosis of cancer. Beyond her professional work, Professor Cairncross is a passionate advocate for the right to health and has tirelessly campaigned for improvements in the quality and accessibility of healthcare. Her involvement with organizations such as Treatment Action Campaign and the People's Health Movement of South Africa highlights her commitment to health equity. She has also been an influential voice in public discourse on health policy, including the National Health Insurance proposal, and runs community training programs to emphasize the importance of a strong, well-resourced, and community-centered public health service. As head of the Department of Surgery, Professor Cairncross aims to integrate her subspecialist surgical expertise with a robust public health and equity perspective. Her vision for the department is to be service-oriented, lead in innovation, and create a seamless pathway to surgical care that connects communities to excellent primary, secondary, and high complexity tertiary care. Professor Lydia Cairncross, it is a pleasure to have you here with us today.
Thank you very much, guys. I feel like the podcast is done after the intro. Thank you very much.
That was quite a long intro,
but kind words. Thank you.
But we do have to hype up our inaugural
Thank you.
guest. So yeah, we'll just move on to the questions. So. First question, we're just going to ask about your career and how you got into where you are. So the first question is, what inspired you to pursue a career in medicine, and what was your journey like into this field?
So I think I decided on medicine quite late in my high school career, probably grade 11 or 12. I'd been actively discouraged to do medicine by my mother, who's a doctor. And she said, do dance or music or something else. So I did medicine, but I had also had an interest in astronomy, interestingly. But I definitely wanted a people-centered profession, and I thought medicine is so versatile, and there's so much you can do with a medical career for others, and it's an impactful kind of job. And also fun. So I applied to a number of universities and I came to study at UCT.
Oh, that's incredible.
And then specifically, obviously during your medical school career, did you have a specific specialty in mind, and what kind of drew you to surgery initially, and then specifically also academic surgery?
So serendipity is a big part of my career path. And you'll find that, I'm sure, in life, the biggest decisions that happen to you are often not planned. So when I was an undergrad student, I I loved most parts of medicine, actually. I got the medal for public health, interestingly. But I enjoyed both medicine and surgery and pediatrics very much. So I hadn't decided what I was going to specialize in. And then it was only during my internship and community service time. So first operation I did was a cesarean section, as it is for most doctors. In my internship, that's when you do your sort of obstetrics block, and you actually get to do something real after medical school, which is great. And I remember just feeling quite comfortable in theatre, and it was someone's very passing casual comment saying, "Hey, you did that quite well," when I was closing. That just stuck with me, and it's interesting the impact that your trainers can have on your life. So I thought, oh, that's great, but I wasn't that keen on the whole kind of or aspect of the obstetrics. So that kind of was in the back of my mind, and then I did my community service in Umtata, and I really loved pediatrics, but peds in Umtata General was quite emotionally taxing. So there was a lot of kwashiorkor that we were treating at that time, and the health system was weak. So we would come in the morning and have to check whether there were babies that hadn't made it through the night, and that was difficult. And when I did my medicine block, it was in the midst of the HIV epidemic, and you're too young to know this, or to remember it, but in the early 2000s, we didn't have access to ARVs. Not only didn't have access, we were not allowed to prescribe them, and doctors had been disciplined for writing up ARVs because of AIDS denialism at the time. And so, if working in medicine, and then I was at Livingston Hospital in what was then PE. Medicine was a very depressing sort of space, because we couldn't help a lot of people. So people were dying of PCP, sometimes pneumonia. We didn't know the difference. We weren't doing CD4 counts, and we were just watching, person after person not making it. And that's actually how I got involved with TAC, is through that experience in the wards. Seeing how futile it was what we were doing, and I went to a TAC conference, and I saw people who were HIV positive but well and vibrant and energetic and struggling for their rights, and I was really inspired by that. It was really a formative time for me. So in the wards medicine, I couldn't do anything, and then when I did surgery, I could do a lot. So appendicitis, then you take the appendix out, and the trauma laparotomies, and I like the edge of theatre, and bit of an adrenaline rush, and the impact of seeing there's this thing, and then you do something, and the patient is better. So I think, funny enough, my interest in surgery grew partly out of a lack of faith in kind of conventional medicine. I was like, I don't know, like the hypertension, we weren't really having a lot of impact. And now with the lens I have now, I see that's because we weren't impacting on society. And so you can only do so much with the end of that disease process, which starts with poverty and inequality and poor housing and poor nutrition and poor access to primary care, and then ends up with uncontrolled hypertension. And I think I just felt more useful in theatre at the time.
Interesting. And specifically, like academic surgery, so teaching, I know you mentioned how a passing comment was like quite instrumental in your career path. So do you think it was maybe how that effect had on your career, the desire maybe to have that effect on students' careers, or?
So I think I hadn't always decided I was definitely going to train as a surgeon, but when I worked in Port Elizabeth, I'll never forget, I took a patient to theatre with a stab abdomen with the bicycle spoke. Tiny little entry. And at the laparotomy, there was this big retroperitoneal hematoma, and which I opened, and I tried to go, and I didn't know what I was doing. So I was trying to control this thing. We called the consultant in. I mean, the patient was fine and they made it, but I thought to myself, I should probably learn how to do this properly. And so I decided to do surgery, and really Professor Khan was instrumental in both me coming over to take on a reg job, because I met him when he came for a visiting lecture in Port Elizabeth, and also later on when I was a consultant. I wanted to be a district level surgeon. I wanted to be a general surgeon and work in the community, and I wasn't interested in academic medicine. And Professor Cairncross said, "You're wrong." And I said, "No, I'm not." And he's like, "Well, just try this." And so a post opened up in the breast and endocrine unit with Prof. Panieri, and then I got involved in academic medicine and teaching, and you don't actually realize what happens at a teaching hospital until you're teaching after a few years, and how much reach you have by being in that position. And many years later, he said to me, "You see, I was right."
That's incredible. So parallel to your academic journey, you've also remained a steadfast, to put it lightly, a steadfast activist. And so we were just wondering what drew you into activism and what keeps you engaged in this activism.
Yeah, thanks. So I think, I think I've told this story before, but I came to medicine through politics and not the other way around. So I've grown up in a political family. I've always been engaged in various forms of struggle and protest, and from high school days and beyond. And I think there's always a yearning to connect with people at a grassroots level, which has come from that early grounding that I had at the time. So I've been in trade union meetings and late night political conferences, and Chris Hani's vigil at the big FNB Stadium in Gauteng, like that kind of whole period of time in our history, which was so intense, that I lived through as a high school student and then at university. So I've always had the sense of an incomplete revolution in South Africa, of an incomplete change. And so I have kind of had two, I wouldn't call them careers, but two paths that were quite divergent for a long time. And funny enough, it's academic medicine that kind of brings them into some kind of overlap, because clinical medicine is quite clinical. But academic medicine is different, because there's a lot of advocacy, a lot of change, a lot of systems thinking that comes into it. So I think it's quite easy in South Africa to live in a bubble, particularly in Cape Town. If you don't, cross beyond a certain invisible line, you can think that everything is fine. And so I try quite consciously to not stay in that bubble as much as I can. I mean, if you work in a public hospital, of course you see a lot, and everything that unfolds in society eventually ends up in the health system, from trauma to malnutrition to substance abuse. We see it, the end product. And I think seeing that over and over again kind of makes you realize that we're fixing this one corner, but actually the root cause is beyond this. And so it's in that complexity that I try and stay engaged as much as I can.
Wow. I love how you said that the academic aspect of it actually brought the two, as you said, like divergent paths together. I find that really cool, that like you were able to bring them back together. So following on from that, what would you say your thoughts are on the duty of healthcare workers in advocating for social change?
So it's not as straightforward as health workers must do this because they're health workers, because I think sometimes that becomes a narrative which sets people up for overwork and burnout and stress and strain. So I think we're well placed because we can see the ills of society, and we have this care imperative to do a lot. But I think everybody should be engaged in advocacy for change. I think with health workers, and as you come out of your medical school and become junior doctors and then senior doctors, it's to find the point of intersection where you can see this is something that moves me to action. I have influence over it, and I can try and do something. And even if it's a small thing, to keep on doing those things, because I really believe that with critical mass, if enough people are doing that all the time, things will get better. And as a doctor, you are a change agent and you're a force multiplier. People look up to you, and every single person you interact with, you can have a profound impact on their life. So it's an incredible opportunity, actually, to do things. And even if you're having the worst day and you're like, I don't know if there's any point to my existence, you can still get up and go to work, and you have the opportunity to help someone. It sounds quite kitsch, but it's really true. So when you're like, the politics and the meetings and I've written all the stuff and nothing, in that one day you can still go to work and engage with someone in a particular way, look them in the eye, even if it's relieving pain or making a diagnosis or speaking to a family member. And that's quite a profound honor, actually, that you get from the medical profession.
I mean, I guess it's like you're already so involved with people. So the more you can do for people, it's like with the advocacy and sorry, that's amazing.
Yeah, I think it's quite interesting how you're talking about the non-medical and the non-clinical aspects of a doctor. And obviously the clinical aspects and the knowledge is quite important. But what would you say if you were to draw up, what are the kinds of characteristics and skills and aptitudes of a junior doctor that is extremely important for a junior doctor to have?
Oh, sure, we're recording this, right? So, I mean, I think the grounding of a good doctor is being a good doctor. Like the clinical stuff is really important, and I think we mustn't forget that in building in everything that we need to build in, because it gives you a certain degree of confidence, and people are relying on you to know the right thing to do and to know when to ask for help. So being confident in your clinical ability and your clinical skills is, I think, the first important thing. And then I think we need to find a way to include in our curriculum the ability to communicate with everyone in a very connected and genuine way. So what I mean by that is, whether it's the professor on the ward round who's asking you a question, or the porter, or the nurse that's filling out the drug chart, because medicine is so hierarchical. And I think we have to start to change that from how we train in medical schools, in health sciences faculties. And so that's something we inculcate. And then I think the third aspect would be a wider lens. So just an awareness, treating the person in front of me, and just to open the lens a bit and say, okay, where's this person from? How did they get here? How are they going home? Is there food when they get home? And you may not be able to do something about that every time, but that's a humanizing lens to see someone with something bigger, because when you see that, then you start to say, okay, what about if we did this, or if we changed that, or could that also come into play as well? That's answered that.
I think it did answer that quite well.
That was a great answer.
I'm just curious if you think those aspects that you mentioned, do you think they play into one another, into strengthening each other? For example, like with the context of someone, or your thoughts on how the context of someone would affect your clinical exam and how you approach them clinically?
I think so. I think we lose a lot of information by forgetting to connect to family and directly to patients. And of course, language is critical to that, not just which language you're using. That is a huge part which we don't do well, but also the type of language that we're using. And remembering, I am, if you're standing with someone, you're a content expert on your knowledge, and they're an expert on their illness, and the role is to find a way to communicate that across. I suppose the thing is to just be a real person, and patients can feel that, and not to put on too many layers between you. And I think it makes people better doctors.
It's insightful to hear. And so you've spoken about your ideas for change in medical school with the way we teach. So what kinds of specific things or other areas do you think we could change about the way medical schools are either run or curriculum that you think would have a difference in achieving what you've described as a good doctor? Big question.
That is a really big question, and we're grappling with it. I'd love to tell you I have the answer. So far in my HOD time, the first year and a bit, I spent a lot of time working on the postgraduate program and trying to help our registrars to have good training as they go through. And now I'm looking at the undergraduate program and where we intersect in as surgery quite late in the program and in quite a fragmented way, and not necessarily teaching that magic of the whole surgical journey. So you see something and you diagnose it, you operate, and you see the patient afterwards. And I would love for us to find a way to give students that experience of what that looks like. And I don't think we've got it right at the moment. And then, we're trying to integrate some talks on global surgery, advocacy, understanding the pathway to surgical care. But I think once off isn't enough. So integrating that across the curriculum is what we need to look at. But it's not easy to change the whole ship. And I think there's so many components that it's not going to be quick. Is what I'm realizing. So, and I'm hoping that, when I leave, I'll leave it looking a bit different, at least in surgery. But I'm very aware that there's still a lot of work to do.
Definitely.
I think you spoke about fragmentation, which is, I think, an issue that we struggle with at all levels of education and medical education specifically. And it's also a trend that's reflected in the higher levels of medicine, and especially in the global north, I think, where we have an increasing fragmentation and sort of hyper-specialization, where everyone sort of focuses in on their own niche. And my question is, what do you think that hyper-specialization, perhaps even increasing fragmentation, what effect that might have on patient care?
No, thanks. I think that's an excellent question. And as a subspecialist surgeon, so I like to think that I'm a subspecialist surgeon, and I'm trying to, and I'm often finding myself defending the generalist in our system. And I think we need both, but we need to change the hierarchy around medicine. So, and we see this coming in with increasing specialization and subspecialization, the return of generalists like family medicine, even emergency medicine, which is a broader specialty, to address this fragmentation, because the person comes with just the one body and there are like 10 different doctors that are doing different things. And so I think we need a broad base of generalists, and we need a smaller layer of specialists and subspecialists. Then we need to flip the hierarchy. It's actually more difficult to be a generalist than to be a subspecialist. By the time patients come to me, they've often kind of been packaged with a lot of stuff we know already. They've got a CT scan, thyroid function tests. They've had it. Sometimes the diagnosis is wrong, but often it isn't. So there are a lot of things that have already gone into what's happening here. Whereas if you're a generalist or a GP or a family medicine person working in a small CHC, you're seeing 100 patients, and one of them is going to have a strange cardiac arrhythmia. One of them is going to have a fear every 3 years. One of them is going to have something that needs admission immediately. And, deciphering that from everyone that you're seeing is a skill. And I think we don't honor enough, we don't give enough recognition to the skill of generalists in our system. And if we do that and we flip the hierarchy more, then I think we will get more balance in the healthcare system. Because it's not only that the super specialists are very fragmented from others, they also are often at the top of the academic pyramids and have more voice and say than some of the others. So we need to shift that. And then at the same time, everybody needs to have access all the way through up to subspecialist care. So it shouldn't be the case that whether or not you get access to a good neck dissection for thyroid cancer depends on where you live and how much money you have, which is the case now. So if you live in some parts of the country, you cannot get an operation for medullary thyroid cancer or for advanced papillary thyroid malignancy, just speaking in my domain. That shouldn't be correct. So we need to have a few of those people in the country, but every single person in the population should have a referral pathway that takes them to someone who could do that procedure when they need it at that level of expertise. And everyone should have the right to that.
100%. So I think this kind of follows on from what you've just been saying about just the education and just everything that's happening with healthcare in South Africa. So what is your vision for South African medicine and surgery? And we're not asking for the answer, but what do you see as the way forward for us to get to that goal?
Okay, sure. I'm trying to curate
Yeah.
what I'm going to say because it's so much. So I think, first of all, we have a huge potential in the health system in South Africa, both in public and private. And I don't think we must underestimate what that means on the continent in terms of the human resources, expertise, and academic knowledge and specialist knowledge that we have in South Africa. And we have a foundation for a phenomenal health system.
Yeah.
We really do. So how are we going to get there? Because at the moment we have this massive skewed distribution of resources, and we have good people working on both sides of the system, and the patients kind of get missed in between in the private sector, overcharged, overserviced, and sometimes not the correct thing done. And in the public service, not enough for everybody, and in some centers, really quaternary care happening.
Yeah.
So I think in the year that NHI has been signed into law, the one thing we should not have done is cut the health budget. So for me, it was a profoundly cynical move to legislate that and then to undermine the only health system that can reliably and sustainably deliver healthcare to the population.
Yeah.
So any new health system or any reformed health system in South Africa has to be founded upon a strong public health system. And that is what we need to strengthen.
Yeah.
The way to strengthen that is by resourcing it, improving management at facilities, and by regulating the private sector. It goes hand in hand. If you don't regulate the private sector, you can't strengthen the public sector because you get a constant brain drain across, and the imbalance between the two continues. So both need to happen simultaneously. You have to create posts in the public sector and employ doctors. I'm sure you're all hoping to be employed one day. Employ doctors who are willing, and there's so many people willing to work in our state sector, and fund it properly, and regulate the private sector so that it takes an appropriate size and shape in this country, which is much smaller and much less powerful than it is at the moment. And you actually don't need major legislative change in order to do that. You need to implement policies that we already have in place. So that just gives you a snapshot of, I think you can
that was a great answer. And you actually helped because my next question for you was actually about the budget cuts in South Africa. And so we've seen that the healthcare system has been massively impacted by these budget cuts. And we just wanted to know, in your opinion, how has this affected medicine and surgery across the country for both patients and doctors? But I think you did kind of touch up on that already. But.
Yeah, I think South Africa hasn't had a significant cut in the health budget for 15 years. It has actually either been steadily increasing slowly or staying almost the same.
Yeah.
It's hard to imagine that because we have so many problems in the country with the health system. But we have, around Cape Town, had a disconnect between the political leadership of the province and the management of the health system, which has been hugely beneficial. And the successes that we've had have not been because of party politics. They've been because of a number of very committed senior health managers who've been allowed autonomy to run the health system without political interference. They've also been allowed longevity, so they stayed in position for 5, 10, 15 years, many of them. So you accumulate. And I'm saying this because it's part of what we need to think about in other parts of the country. We need to disconnect our civil service from the fluctuations of the party political system and allow people to professionalize, allow them to stay relatively autonomous and to manage things well. So I say that as a backdrop because a budget cut is therefore a massive, massive change for us in the Western Cape. In other parts of the country as well, though they have had problems with overspend on their budget and running out of consumables and sometimes having to freeze posts intermittently. So it's affecting those areas as well, but we are feeling it really acutely because we haven't had an actual cut for quite a long time.
Yeah. Okay.
So 5 to 10% cut in your health staff is massive. There is no way that you can innovate yourself out of that kind of cut. So patients are suffering, will wait longer, are waiting longer, will die and are dying because of budget cuts. And you can try and politic it any way you want to. If you cut the health budget, people die.
Yeah.
That's what's going on. We've lost almost 1,000 operations this year in this hospital alone, and we've lost 350 operating lists. We have over 4,000 patients waiting for surgery. I'm looking tired like this because I'm trying to get our theatre schedules back to something reasonable. And part of advocacy is kind of how is it that the general population doesn't know about this, and then an election year that the state can get away with this, and what is happening in health is also happening in education. So we need to be saying as a society, how do we protect the foundation of our social fabric, which is health, education, basic services, from what is happening either in the political or economic domains. And that's another conversation, but that gives you a sense of where we are, which is not a good place right now. So,
So you've spoken a lot about the NHI and how the financial and the budget cuts have affected kind of the success or the potential success of the NHI. Do you believe that a restoring back of the budget is what's essential for the NHI to have success?
So there are many things that we need for a successful health system, and an NHI funding model might be one of them. But you're quite right. We actually have to restore and build the public sector before we can even begin to think of a successful, the successful reach of any kind of national health insurance. It can't be based on the private sector. So that's, for me, if people speak NHI, we have to say, what are we doing around the health budget? How are we strengthening public health facilities, not only in the places where we can see them, but in small rural communities as well, where there are no private facilities for them to benefit from NHI. And that's the real conversation.
I think it's also what you can see and what you can't, also what you will see and like what you don't want to see. Especially in Cape Town, it's definitely more of a bubble, and a lot of people don't want to look beyond that, just even in the health sector, but also in the general public, I think. And that's probably also influencing a bit of the opinions or varied opinions on NHI as well.
I think it's also important to recognize the intersection between a lot of these issues. NHI connecting with the budget cuts and that brain drain you speak of, and people sort of leaving the public system. And that sort of ties in quite nicely with my next question, segue and a half, which is the unemployment that you touched on a bit earlier. We've seen on the news about, there's 800 doctors that don't have work. And the question is, if there is a shortage, given the shortage of healthcare workers, including doctors, and the complication that is complicated by the lack of posts and the freezing of posts, how do we foresee this issue evolving, and how would this affect healthcare workers and patients alike?
I think that what is happening to junior doctors in this country is a travesty, and we should be ashamed of it as a country. I think we have increased medical school intake, and we haven't increased posts to match it. We are saying that we don't have enough doctors to work in underserved areas, but we are not creating posts for that to be possible. So we need political will to change that, and budget to go with it. So I'm hoping that there will be a bit of a wake-up call, because I don't think we've ever had a situation where we've actually been faced with numbers like this of unemployed doctors. I'm optimistic that there will be a wake-up call. It's quite shocking to the system to see that we've got this. And that essentially there's a layer of within the system around the medical officer post level, which is underfunded at the moment. And we need to create more of those posts. So there's a transition from internship, comm service, medical officer, and then specialization if people so choose. And I mean, I think there's also a lot of discussion happening around the length of internship and how that plays into the job shortages in the medical officer space. So there's some important conversations that need to be happening. I think some of them are happening at the level of colleges and the dean's committees and those kinds of areas. And I hope that junior doctors don't stay quiet and continue to speak out, because it's not for their personal benefit that we need to do this. That would also help for them to but it's actually for the country. And it's a funny double speak to say we don't have enough doctors, and but then we don't employ them, and actually we probably have got enough doctors. We've got a maldistribution of doctors.
I think this touches on a lot of what you said about academic medicine and the position, whether appropriate or not, that academic physicians have in advocating for social issues. And I think the position of healthcare in society and its power for change. I think the next few questions are going to sort of flip back right onto you again. And this one is just an open-ended one about what have been your greatest challenges to getting to where you are now.
Sure. Okay.
It's fine. Sorry.
So greatest challenges. Sure, that's a tricky one. I think time. There's just not enough time, and I have been grappling with trying to have a more balanced life for a long time, and I keep thinking I'm almost there with the solution, and then I'm not quite. And I think the challenge is seeing so many things that need to be done, and then seeing what can be done, and then knowing that you probably could do it, and then not being able to do all of them. I think that's probably the biggest thing, having to choose where to put your time, effort, energy, passion at any one time. So if I'm running a big department, there are things that I'm not spending as much time on that I might want to. So I'm not able to maybe do as much research as much, or writing or reading, or I might have wanted to get home earlier every day and be with my kids. So I suppose it's trying to figure out how to choose the best way to spend every moment that you have. And to see what comes in the workspace, in the community space, in the private space, in the family space. That's probably my biggest challenge.
You've been giving us such great segues into our next question. So with acknowledging the fact that the fields of STEM and medicine and surgery have generally been more historically male dominated, I just wanted to hear about your experiences as not only a woman but also a mother. As you just said, you mentioned your kids in medicine and surgery and academia, and maybe even touching on time as you just did now.
So when I became a registrar, there were no female consultants in the department. And then when I finished, we were sort of seeing one or two coming through. We're now at about 25 to 30% female consultants, which is great. And until recently, there was only one female head of division, and now two, soon to be three. So that is slowly changing, but it's taking time, and it is still a very male-dominated field. So I will often sit in a meeting and I'll be the only woman there. I think mentorship has been quite important, and that doesn't always have to be a mentor that looks the way you do. So I had mostly male mentors actually through my career, and I have managed to come through it quite unscathed. Actually, it's been fine. I can see when I move in spaces where I'm not that well known, or go to another hospital or national meeting, I sense it again, the assumptions that people make about who you are and what your capabilities are. So it's still there, and it's very, very real. And we need to constantly be aware of it and push back and raise consciousness around what does a surgeon look like, what does a maths professor look like, what does a scientist look like, and sometimes just being in the space helps to change that narrative. And there are lots of stories from the clinical space, and so it's actually at the moment it's more patients that sometimes, not so much now, but in the past they would be like, okay, this is the but it gets better. And of course, with patients, you have a lot more empathy and patience than you would have with senior colleagues. So it's a contested terrain, though I haven't felt it very personally for myself most of the time. And then, so I'm actually quite a normal person. So I have, people are like, oh my God, if you're going to be a surgeon, it means like you're not going to have a personal life and you never do anything else. And that's not actually the case. So, I mean, I have 2 kids and they are now 10 and almost 13, 10 and 12. So Lanika and Livumile, and they keep me very busy.
Yeah, for sure.
And when they were very young, I thought I'd explored the depths of sleep deprivation surgery, but having children is next level. There's nothing like it because the call doesn't end. It's like a continuous sleeplessness. So I think the early years with small children are difficult. I was lucky enough that I took 6 months maternity leave. I got extra time off. I came back part-time for 6 months.
Okay.
Which Professor Khan allowed or supported. So with both of them, I had a bit of extra time. And when they were quite small, I did all my academic work at night. So I would go home in the afternoons and spend time with them, and I would try to pick up from school and so on. It's a slightly different phase now. They're a little bit older. They need me in different ways. So a lot of homework, studying together, piano practice, drawing, all kinds of things, art. And it's really good to have that balance. I think if I didn't have kids, I'd be a disastrous workaholic. So the children ground one in having, you need to go home at supper time, it's bath time. They want to play on a weekend. So I'm quite intentional about my weekends. So I mean, it's exceptional for me to work on non-clinical stuff on a weekend. So I close my computer on Friday evening, and I try not to open it until Monday again. Now and again, I don't get it right, but it's like one of my boundaries. I really believe that you need to try and switch off when you get home. I don't always manage it, but it's an aspiration. So I try not to work a lot at night. I mean, as in working on the computer. Though many people do that, I find that I think it leads to burnout, and it's not healthy. So I'm constantly exploring that. What does it look like to deliver everything and look after what you need to at work? And I'm responsible for a lot of people's careers and their lives and their progression and patients as well. And yet also be able to switch off and be your best self when you come the next day. So I think that's kind of
I just I love that you said that when you're surgery you don't have time, because that's what everyone tells me. I mean, I've even had my friends telling me who are studying different things, like, you're like, how you don't have time for anything, like how do you I mean, I still have a social life, I still see people, like and again, the thing of when you're a surgeon, like, you have no time, like it's going to be really hard to start a family, like that's something that like is still like said a lot, and like you hear a lot. So hearing you say that is
it's reassuring.
It's reassuring, to say the least.
And it's a very gendered caution that comes through, because when people want to do pediatrics, no one says, you're going to have a family and you're going to be too busy. Or obstetrics and gynecology, where there are a lot of women specialists. Those are really busy specialties. On call is hectic, out at night all the time, late, sleeping in often in the hospital. But somehow there's not the same narrative as there is around surgery. So it's not worse than those disciplines. Look, when you're training as a registrar, it's rough. And you will not sleep a lot, and you're busy, and for those 4 to 5 years you're kind of focused in on that thing. And I think having children while training, which many people do, because you should be able to have your kids when you want to have your kids, that is quite hard. But I think afterwards, when you're a consultant, you have more control over your life. Yes, it's still busy, but it's not undoable. And a lot of fairly healthy, balanced people are doing it. And I think my kids are fine. I'm sure we'll hear one day how it is and how it's gone.
I think you mentioned earlier about burnout, and you've spoken a bit about how you intentionally try to craft your own work-life balance. So what would you say is the importance of increasing the knowledge and importance of work-life balance and preventing burnout in the healthcare profession?
I think it's very important. I think we need to normalize we need to stop normalizing overwork for the sake of overwork. So it's often necessary to work really hard, and we need to do that, and we need to stay late if we need to look after someone who's sick. But I think medicine's gotten caught up in a narrative where it's really good to work very, very hard, and so you should always be appearing to work very, very hard, and you should never be saying, I need to rest and relax. So I think flipping it by saying, actually, we need to be intentional about you work really hard and then you take a break and you switch off completely. So, I mean, I look at the academic surgeons around me, and the clinical work is something you do and then you go home and you worry about your patients, but you can't continue to do it at home. But the academic work you can continue to do anytime, holiday, weekend, nighttime, all the time. So, like with other jobs as well, the question of boundary setting. And what I've realized over time, because so I'm I haven't achieved this, right? I don't have the balance, but I'm trying. So when I'm really, really overstretched and I'm having, I've got too many meetings and too much going on and a big theatre list and lots of stuff to respond to, I'm not as good a person as I am when I'm not that tired. And that's become clear to me, like really clear to me over time. And the kind of leader you turn up, you show up as every day is very different. And because we have impact on so many other people, when we pitch up tired and irritable and stressed out, it's not good for the people around us. So even if you want to be like selfless about it, even from that perspective, we need to try to balance more. So I try to get to yoga, I try to do breathing in the morning. Don't always manage, but I try. I try to switch off and regulate. I've read over 35 books on time management, so I could do a whole speech on it, but I won't. Exploring different techniques and strategies, and I even thought, maybe I must go become one of those people that don't do anything. And I just be calm and quiet, but then I realized that's not really me. And I'm looking for the Holy Grail. I'm not quite there, but I think we just have to continuously try.
I'm curious what you think. Do you think an aspect of having work-life balance, preventing burnout, is also a sense of self-confidence in what you've done and being able to call it at the end of the day and be confident that when you go home and you stop, that you've done enough and that there isn't more that you should be doing? Do you think that's a part
That's
of
a really wise comment. I think so. And even, I mean, that's quite aspirational as well, to be able to say, I have arrived and I've also done the work of the day and now it's closed and I'm home is a very important strategy. One of those that, because it's counterculture actually, we have to keep reteaching ourselves. And I mean, medical students and doctors, we're all kind of like driven and ambitious and bright and full of energy. So we are at risk of this thing of not knowing the boundaries of our energy. And sometimes when you have people who are extremely competent and can do a lot, you don't think that there is any boundary. You can just keep adding more things on, and it's only when you tip over the edge that you're like, whoa, that was actually too. Everyone has a ceiling. But what we need to learn is how to see it before we hit it.
I think it also plays into the idea of lifelong learning, but then also just continuous learning, always wanting to know more and do more. And that's an important skill to have, I think, as a doctor. But then also knowing when, as you said, you've reached the ceiling and there's no more to be done, or it needs to stop for that day. It's also very important.
It's stretch versus strain.
I think our next question also takes a bit of a turn. So you've spoken a lot about your career and the kinds of experiences you have had that have influenced your career choices, and especially your work in pediatrics and that kind of thing. So what would you say over your very long career has been your most memorable, impactful patient encounter? And what about it was so profound that it's left an impression on you?
Sure. There are quite a few memories that I'm going through. I think it's actually not in the operation. I'm just thinking of a an elderly patient that we were preparing for surgery, and she took my hands and she prayed on them, and it was just such a profound, not religious person. It was such a profound moment, and I could just feel that connection that she was connecting to me, and she was connecting to her own faith and belief, and she was saying, that was something that really touched me.
Was it almost a sense of, she was saying we're doing this together and connecting the two of your experiences, as if she was, she identified the connection that you two would have during that time? Is that maybe what it was?
Maybe it was that. Well, she was blessing me, basically. It was really lovely.
It's amazing.
It's always those weirdly inconspicuous moments that stick with us. Even in my very limited clinical time, I can think of small moments that maybe at the time didn't seem so significant, but in reflection, you start to realize how they might have perhaps just tweaked the trajectory of your professional life. The next question is just bringing you back to the medical school days, and just reflecting on what were some of your favorite memories from medical school.
I remember we did our elective in SS Gide in 5th year, which is in the Eastern Cape, and we did a cesarean section without cautery, which is incredible, like clip and tie. It took a really long time. And just that whole experience of the drive and seeing a completely different place, and the clerking notes were kind of 8-year-old diarrhea plus, like, that's an examination. So I remember that. I remember, you don't have this anymore, but we used to get our results. We would finish the exam, so we did no end of blocks, right? So it was 2 weeks, and you'd have your exams Monday, Tuesday, Wednesday, Thursday, Friday, Monday, Tuesday, Wednesday, like mad. Then on Friday, you get your results. And you wait at home, because if you didn't pass, then they're going to phone you and tell you.
Oh, wow.
That's why they've changed it, right? So I remember that day vividly, and waiting by the phone, because there were no cell phones, to see whether or not you'd be phoned. And then if you're not phoned, then we'd all come to the quad outside, health sciences, and wait for our results, and then put them up on this huge board. I know.
just name it all.
Names and results.
Wow.
And on a board, and everything is all up there.
I could not imagine.
Things have changed a lot.
I was about to say, I don't know if that would go down well.
No, it was changed for a reason. But I remember like the stress of that, and then the elation of being finished, and it's just like this profound relief of being done with the test. So that feeling, that post-exam feeling, is not easily replicated in life, actually. Like the relief and the just feeling light and happy, and you can just go and like do nothing.
Yeah, and it's like taking a breath of fresh air when you step out of that exam room for the first time. It's like, okay, I can breathe a bit. I
think it's interesting that reflecting back on medical school days, the favorite memory is being done with exams.
Finishing exams,
speaks a lot to our population.
The highs and the lows.
And straying a bit away from medicine, is there anything else you would have gone into if not medicine?
Ooh, that's hard to imagine now. I think,
I'm sure.
I could have been a journalist. I love writing. I've always had this fantasy of going to like war-torn areas and having those multi-pocketed cargo pants with all the things and the little notepads and your camera, and obviously maybe not have panned out with kids, but so I think I would have enjoyed that. So something around journalism and writing, I think. And travel.
And with travel. So it would be more like a. Would you think you would have still gone like a bit of through that activism route with that, through your journalism as well? Yeah.
Remember war journalism.
Oh yeah, war journalism. Sorry, my bad.
So,
that's incredible.
But I still think that I've got a second career as a writer coming later when I'm older.
Yeah.
We'll make sure to promote your book on the
yeah,
podcast when it comes out.
Just it's up, it's coming.
Yeah, it's coming soon. And then just one more question for the budding academic surgeons and medics. What would be your advice for success in med school and beyond med school?
Okay, so I think in med school, I don't think you need to worry too much about the area you're going to specialize in.
Yeah.
So I think try and enjoy everything, engage with each part. Whichever specialty you go into, the other specialties will contribute to your success in that field. So well-grounded, broad-based. I mean, surgeons didn't all get firsts in surgery when they were medical students. Actually, I did, but I mean, it's not a prerequisite to have done exceptionally well in surgery in your undergrad in order to become a surgeon or any specialty actually. And then I think to just relieve the pressure on trying to decide, I must know before whenever that I'm going to do this particular area, because there will be many factors that you can't predict that will guide you which way to go. So it's kind of always a head and heart decision that comes together. When you do finish, I mean, on a practical note, if you want to do surgery, probably the most important thing is to get some operative experience. So if you're in internship or comm service, try to go to theatre, try and do some operations. If you're in a smaller place, ask someone to show you or supervise you to do some smaller procedures, or basically be using your hands in theatre as much as you can. And then the exams help you to get into a registrar job, the primaries, but those are usually not as difficult to get as to get the medical officer job in the kind of hospital where you can learn, where you can practice surgery. So I would say post-com service, your priority is to get a medical officer post in like Mitchell's Plain, Kimberley, George, a smaller hospital, not one of the big, not a big one necessarily, and then do your primaries. Involvement in research is good, but it's not essential. Okay, you do research when you're there with us. So.
I think we're reaching the end of our interview, and the next questions are potentially the most important ones that we will ask you. These are our rapid fire questions. And starting with the most important one, what was your least favorite subject in medical school?
Anatomical pathology.
Oh, really? Wow.
What about it?
I think it was just the way it was taught, actually. And there was one of our lecturers used to shout at us and hold the jars.
Oh, no.
What is this? What? So I don't think it was the subject as much as the pedagogy.
Maybe just,
what's your favorite pastime activity?
Reading.
I can share that.
Everything. I read fiction and non-fiction and time books and nonsense and non-nonsense. But I'm always reading something.
One recommendation for our viewers?
Oh, yeah.
No, I'm not going to go.
Rather not.
Too many.
Oh, no, it's your future book.
Oh, yes, of course, yes. Of course.
Are you more of a beach or mountains person?
Mountain.
Yeah, mountain. Fair enough.
We have a beautiful one this side, hey?
Yeah.
And then, do you prefer tea or coffee in the morning?
Coffee.
Yeah, I was expecting that answer from a surgeon.
Early bird or night owl?
Oh, I'm a night owl. I know, and then I chose surgery and you have to wake up so early in the morning. But my mind comes alive late at night, which is a problem for my sleep quantity.
I have to agree with you there.
I agree.
And then I think it's the last question, and like we said, it's important. What would your go-to karaoke song be?
Ooh, like if I had to.
Yeah, if you had to.
I have sung Guantanamera once. It was ill-advised and didn't come off well.
That's incredible.
So,
I think
that brings us to the end of our conversation today. Thank you so much, Prof, for joining us here on our inaugural episode. We've really appreciated hearing some of your insights from all kinds of things, from karaoke songs, books, reading, and then advice to junior doctors, as well as your opinions on some of the problems that face the South African healthcare system. So we really appreciate you for taking some time out of your busy day to spend it with us here. Thank you so much.
It's been a great pleasure.
Thank you.
I came to this podcast interview quite tired and flat, and I'm feeling much better. So thank you very much for providing your amazing energy.
It's been a pleasure.
It's been an absolute pleasure.
And the last thank you to our viewers who are watching right now. Thank you for tuning in, and please be sure to keep an eye out for many future episodes to come from the Surgical Soul podcast.